Dr. Sarah White, group leader of the Developmental Diversity Group of the Institute of Cognitive Neuroscience in UCL, and Royal Society Dorothy Hodgkin Research Fellow, spoke to the FIRE Zoom meeting on 23rd of April 2024 on autism in the early years. Sarah is an autism researcher who studies cognitive abnormalities through behavioral and neuroimaging techniques. She's interested in the universality, specificity, and sufficiency of mentalizing difficulties, and of a local processing bias in explaining the core symptoms of autism, and in whether an implicit mentalizing impairment can account for difficulties in other cognitive domains. The aim is to understand autism better so that evidence-based interventions can be developed that are targeted at the source and make a real difference.
Okay, so Nick asked me to talk a little bit about autism in the 0 to 5s period. So we'll just start by thinking about what we know about autism. The first thing to say is that autism has a very strong genetic component, which affects brain development. So it results from a particular collection of genes, which are often called susceptibility genes, and we currently think that's something like 1,000 genes that all contribute small effects towards an autism diagnosis. So we have this idea of genetic diversity that I've drawn here. Those genes are distributed throughout the population, and if you have enough of those genes, you'll receive an autism diagnosis. Now, that's a good thing to know, that it's something fundamental about the child. And that while there are environmental effects that affect the outcome in autistic children, whether you're autistic or not is at least mostly not something that's induced by their experiences or the environment that they've grown up in. But the issue is that we don't currently know what many of those genes are, so there's no easy diagnostic test for autism. So we have diagnosis based on behavior, and this is the DSM-5, which is the mostly widely used diagnostic tool. So the clinician has to make a decision about whether the person in front of them fits this description of social communication difficulties and the presence of restricted and repetitive behaviors and interests. And that's partly done through parent or teacher report, but also partly observation in the clinic. And actually, those autistic characteristics that they're looking for aren't just seen in autistic people. Autistic traits can be seen throughout the population, and we call that behavioral diversity, which again, I've drawn here. And again, if you have enough of those traits, you'll be able to receive an autism diagnosis. But that means that the place where we choose to put the boundary between autistic and non-autistic people is a little bit arbitrary. And it's also something that's been shifting to include more and more people. And you can also see that a fairly small shift in the diagnostic practice and criteria includes a lot of extra people because of the way normal distributions work, that at the edge of the distribution, there aren't many people and people are more clustered towards the center. And we know from studies of autistic traits within the population as a whole that autistic traits aren't increasing. We're not becoming a more autistic society. It's just that we've shifted the diagnostic boundaries of what we call autism. And we can look at some data, like the various studies I've got here that show an increase in diagnosis over the years in the UK. Back in '66, we had a 0.04% diagnostic rate of autism in the population, and a study in the UK in 2021 showed us 1.75%. That's something like a 40-fold increase over 55 years, which is massive. But it's still increasing, and it's now more like 2 to 3%. And here's some very similar data. It's from a study systematically looking at UK NHS data on autism diagnosis over the last 20 years, well, between 98 and 2018. So this doesn't include private diagnoses, I should say, which is a separate issue, but it gives us a good feel for the rates of increase. And here we're not looking at actual rates of diagnosis, but instead at growth. So you can see here exponential growth in diagnostic rates. So over that 20-year period, it was something like 8 times the rate, or an 800% increase, which is what you can see on the y-axis. And one of the factors that is contributing to that increase is the idea of the broader autism spectrum. So changes in the diagnostic criteria have had a gradual effect on who we diagnose. So firstly, if we just focus on the data up to 2013, because the diagnostic criteria changed after that, and these two categories that we've got here were disbanded, but up until 2013, you can see that while the rates of more traditional autism in orange have increased, the rates of the broader spectrum in blue have increased at a much faster rate. So we're diagnosing many more children who are less traditionally autistic. And most of that change is because we're now diagnosing more children who don't have intellectual disability or language delay. So at the moment, only 15% of autistic children have an intellectual disability, whereas back, say, 40 years ago, we would have mainly diagnosed children with intellectual disability and language delay, something like 75% of diagnoses. And also, most autistic children would have been educated outside of mainstream schools, whereas now 70% are educated in. But just getting to that 0 to 5 data, that same data, we can actually see those increases in diagnosis split across different age groups. And you can see that the greatest increase in diagnosis over recent years is in that top green line, which is in adults over 19. Next in the yellow line, which is primary school children, then in the red line, which is secondary school children. And the increase in rates has actually been least in the 0 to 5s in the preschool children. And indeed, although the vast majority of diagnoses are still in children, this has reduced, actually. So over that 20-year period, it's reduced from 91% to 84% for diagnoses in children. So we're diagnosing more adults. But we've also seen an increase in diagnosis, particularly in older children. So we've gone from diagnosing 57% of autistic children in the 0 to 5s period to now only diagnosing 28% of children in the 0 to 5s period. And more than that, the average age of diagnosis has increased across all those groups. So even in the 0 to 5s group, the age of diagnosis has increased from 3 years to 4 years. So that's going to be partly because we're diagnosing more sort of subtle autistic children, but it's also going to be driven by longer waiting lists for diagnosis. And I just quickly wanted to show you as well that we can see a similar sort of pattern in that increase in diagnosis, but split by males and females. Although many more males are diagnosed than females, we've seen a massive increase in the proportion of females who are diagnosed over the last 20 years. And that increase is also seen within the 0 to 5s age group. Not to such a great extent, but we do see more girls being diagnosed at 0 to 5 than we used to. So just reiterating that, we know from studies of autistic traits in the population as a whole that autistic traits are not increasing. We're not becoming a more autistic society. But we've just shifted the diagnostic boundaries, and these extra diagnoses that we're making include more subtle presentations of autism, so especially people without intellectual disability and language delay, and also females. And we're therefore diagnosing later and later. So that means that those who are diagnosed in the 0 to 5 period are perhaps not so typical of the autism spectrum as a whole. They're more likely to be characterized by intellectual disability and language delay, and they're therefore more likely to have high support needs, although that's not exclusively the case. So I just wanted to say something briefly about sort of early diagnosis. So the behavioral characteristics of autism have a gradual developmental onset, and those changes can begin to emerge at around age 1.5 to 2.5. But indeed, although the average age of autism diagnosis is around 4 years, parents typically report their first concerns to health professionals at about 2 years of age. And we do have various early screening measures, such as the MCHAT, which is a parental report of autistic behaviours. But before age 2 to 3, those screening measures will miss many autistic children. And also, on the other hand, many children with broader developmental difficulties will be picked up by it. And even with behavioural assessments, so actually meeting the child, before 3 years, diagnoses are less likely to be accurate. Some children won't be picked up who should be, and some will be diagnosed who probably shouldn't be. And the issue there is that many younger children are sensitive to changes in the environment, which makes it much harder to differentiate autism from non-autism. But diagnosis is relatively stable from roughly age 3 years to 9 years, and certainly from 5 to 9. Interestingly, after at that age, it becomes more complex to diagnose because we're dealing with co-occurring difficulties, especially mental health difficulties, and also camouflaging and compensation, hiding, masking symptoms. So 5 to 9 years is indeed the age at which the majority of people in the UK do actually receive their diagnosis. And that sort of window, 3 to 9 or 5 to 9, seems to be the optimal window for identification. But that leaves this tension between leaving diagnosis till we can be more sure, and yet wanting to diagnose early on in order to access services and interventions. So just throwing out there, perhaps we need access to early interventions before a firm autism diagnosis can be made. So just think about interventions briefly. The main motivators for intervention are early on, barriers to communication and barriers to learning. And hence we have a big focus on speech and language therapy, which you've already heard about. But in terms of autistic behaviour, there are many, many therapies out there, but few of them have actually been found, have an evidence base, have been found to have any form of long-term effect on autistic characteristics. And more than that, intervention itself is quite controversial because there's a question about whether we should be intervening and trying to make the child fit the neurotypical mold. And in fact, there's data to show that autistic children can learn to behave in more neurotypical ways, but that behaving in that way is associated with worse long-term outcomes in terms of mental health. So increasingly, we're looking at interventions that focus on helping parents to become more attuned to their child's needs and ways of communicating in order to make the social environment an easier place for the autistic child to live. And I just wanted very briefly to tell you something about how autistic people experience the world to help you understand why parental education is so important. So autistic people struggle to mentalize, and mentalizing is just the ability to think about another person's mental state, what's inside their head, their thoughts, wishes, desires, feelings, beliefs. It's about putting yourself in someone else's shoes, thinking what they're thinking, and it's a really important skill because it allows us to understand what someone's doing and why they're doing it, what made them behave that way and what their intentions and motivations are. But more importantly, it allows us to predict what people are going to do next. So if you imagine for a moment living in a totally unpredictable world where anything could happen, you might think that that would be enjoyable, but actually it would be a very difficult place to live. And if you can't mentalize, the social world is very hard to predict. Mentalizing is the main way that we predict what other people will do. And the obvious consequences of living in that sort of unpredictable world are that you're going to live with very high levels of anxiety. You're likely to feel exhausted from constantly being on alert as anything can happen. You're going to look for ways to avoid those sorts of unpredictable scenarios. And you may look for ways to increase predictability in your life as a way of coping. And indeed, repetitive behaviors, and special interests, which are part of the diagnostic criteria, are exactly that. They're ways of seeking predictability. So again, this is where parental education comes in because it focuses on helping parents to become more attuned to their child's needs and ways of communicating in order to make the social environment an easier place for the child to live in. And that means being safer, being more predictable, being less exhausting, and being less anxiety-inducing. And interestingly, we also know that children living in greater deprivation are more likely to show autistic characteristics and to receive an autism diagnosis, therefore. So it's clear that the earlier that this supportive environment happens, the better the potential outcome, especially for mental health, but also potentially for education, for employment, and for daily living skills. And from a study 10 years ago now, actually, the annual economic cost of autism in the UK was £32 billion, presumably quite a lot more than that now. But children only represented a small proportion of those costs, as you can see, about 1/8 of the cost, despite representing the vast majority of autism diagnoses. And more than that, mental health outcomes and mental health support represented a relatively large chunk of those costs. So I'd like to just leave you with that thought again, that perhaps we need access to early interventions, and especially parental support and education, before a firm autism diagnosis can be made. Okay, I'll stop there.